Mesothelioma is an aggressive form of cancer that develops from the mesothelium, the protective lining that surrounds many of the internal organs of the body. The mesothelium lines the lungs, pleura, heart, pericardium, abdominal cavity, peritoneum, and testes. Most cases of mesothelioma are caused by exposure to asbestos. Unfortunately, mesothelioma is often diagnosed at an advanced stage as it grows silently for a long period before manifesting any symptoms. Surgery combined with chemotherapy is often recommended for patients with early-stage disease. However, for most patients diagnosed with advanced or metastatic mesothelioma, chemotherapy is the primary treatment approach to manage symptoms and extend survival. T-cell therapies, also known as TIL, tumor-infiltrating lymphocyte therapies, are an emerging treatment approach for some hard-to-treat cancers like mesothelioma. TIL therapy involves extracting immune cells called T cells from a tumor sample obtained from the patient. The T cells are then expanded and activated in the laboratory before being infused back into the patient to induce an anti-tumor immune response. Studies have shown that T cells extracted from a patient's own tumor have the ability to recognize and destroy cancer cells. However, the T cells alone may not be potent enough to eradicate widespread metastases. That is why TIL therapies are often combined with preconditioning chemotherapy or immunomodulatory drugs to improve outcomes. One of the earliest studies to evaluate the efficacy of TIL therapy in mesothelioma patients was published in 2013. In this pilot study, researchers at the U.S. National Cancer Institute investigated the toxicity and clinical activity of autologous TIL transfer combined with non-myeloablative chemotherapy in 12 patients with advanced pleural mesothelioma. All patients had stage IB/IV disease that had progressed despite prior chemotherapy. Under general anesthesia, fresh tumor samples were obtained from all patients. CD8+ and CD4+ T cells were then selectively expanded from the tumor samples. Prior to T cell infusion, each patient received a single low dose of cyclophosphamide to induce controlled lymphodepletion, followed by IL-2 therapy. The TIL product was then administered intravenously to the patient while an outpatient procedure. The researchers observed that TIL transfer combined with lymphodepletion and IL-2 therapy was feasible and well tolerated in these heavily pretreated mesothelioma patients, with no severe infusion-related toxicities. Of the 12 patients treated, 1 achieved a partial response and 3 others achieved stable disease for 8 to 18 months. The clinical benefit rate was 33% and the disease control rate, partial response plus stable disease, was 42%. For comparison, the expected rates of response to chemotherapy alone in a similar group of pretreated mesothelioma patients are usually in the range of 10 to 20%. The study provided early evidence that TIL therapy could induce anti-tumor activity and clinical benefit for some mesothelioma patients. Larger studies were still needed to evaluate the efficacy further. Encouraged by these initial findings, researchers from the U.S. National Cancer Institute conducted another phase-half trial evaluating the safety and efficacy of TIL therapy combined with preparative non-myeloablative chemotherapy specifically in patients with advanced pleural mesothelioma. In the study published in 2018, 15 patients with histologically confirmed unresectable stage 3/4 malignant pleural mesothelioma were treated. Fresh tumor samples were obtained from all patients through surgical procedures or thoracentesis. CD8+ and CD4+ T cells were selectively expanded from the TILs over 3 to 4 weeks. Patients then received a single low dose of cyclophosphamide followed by IL-2 therapy, after which the autologous TIL infusion was administered. The researchers reported that TIL transfer combined with lymphodepletion and IL-2 support was again well tolerated in these mesothelioma patients, with no serious adverse effects attributed to the T cell infusion. Of the 15 patients treated, 2 achieved a partial response, disease control rate of 13%. An additional 5 patients achieved stable disease for 8 to 32 weeks, resulting in an overall disease control rate of 47%. The median progression-free survival was 12 weeks and median overall survival was 44 weeks from the start of TEL therapy. Importantly, patients who achieved disease control had significantly longer overall survival compared to non-responders. Overall, these two early-phase clinical trials suggest that TEL transfer in combination with lymphodepleting preconditioning chemotherapy is a feasible and relatively well-tolerated treatment approach, able to induce promising clinical responses and disease control in a subset of advanced mesothelioma patients who had failed multiple prior therapies. Larger controlled trials are still necessary, but the initial disease control rates of 42 to 47% compare favorably to standard chemotherapy alone. Ongoing efforts continue to optimize TEL culturing, selection of better responsive tumor types, biomarkers, and incorporation of immune checkpoint inhibitors to further improve outcomes. T-cell therapies hold hope as a new therapeutic strategy for the treatment of mesothelioma. Initial clinical studies have demonstrated that autologous TIL therapy in combination with lymphodepleting chemotherapy can achieve disease control rates of approximately 42 to 47% in heavily pretreated advanced mesothelioma patients. The treatment approach appears to be feasible and well tolerated. While further research is still needed, TEL transfer represents a promising new immunotherapeutic strategy for mesothelioma that warrants additional investigation, especially when combined with other immune-boosting therapies. The disease control rates seen so far with this approach compare favorably to standard chemotherapy alone.